Hello, good afternoon, everybody. Thanks very much for attending BTO's webinar on the medical investigation of orthopaedic injury. My name is Tim Webster. I'm one of the associates in the BTO personal injury team. I'm dealing with all aspects of ordinarily defending personal injury claims. And I'm delighted to say that our guest speaker today is Mr. Tim White, a consultant orthopaedic surgeon with an extensive experience of orthopaedic injury and dealing with orthopaedic injury for the best part of this century. I'm going to, without dragging it on, just pass over to him now. Hopefully you've all received the invitation that outlines the extensive range of topics that he's planning to touch on today. And my only question or query to you all is, if you have any questions, Tim has offered to address them as we go, or if you'd rather, put one in the chat bar and then we can pick that up at the end. But I'll pass over to Tim just now, and please just all make sure your microphones are on mute and enjoy the seminar. Thank you very much.
Great. Tim, thank you very much indeed for the invitation. I take it you can hear me okay?
Yes, we can hear you now. Thank you.
Good. Okay, great. I'm going to switch to my slides in just a second. My instructions are to talk for 20 or 30 minutes, and then we'll have some time for questions. But as Tim said, I'm very happy if you want to interject at any point, if there's something that we're discussing that is of particular interest. I'm very happy to stop and take those as we go through. Okay, so let me just switch to my slides there. Tim, are you seeing those okay?
Not yet, but
okay.
From experience, these things take a while to warm up.
Yes, okay. Our practice session worked out very nicely, so I'm hopeful that will now come up. Let me just redo that and make sure that we can. Okay, I've reset that. Does that now appear?
That is them. That is them. Thank you.
We're in business. Okay, lovely. Okay. So I trained in Edinburgh. This is the Royal Infirmary, just to sort of set the scene a little bit. This is the venerable old lady that I trained in, that has subsequently been sold and tarted up and turned into flats. And the Royal Infirmary of Edinburgh has now moved out to a site on the outskirts of the city and is now quite a modern hospital. I have an office here with a suite of theatres dealing with trauma, and what I like to call my helipad sitting on the top. Our own department serves a population of 800,000, tertiary referrals from 1.5 million. It's quite a busy orthopaedic centre. We deal with about 15,000 A&E referrals into our department locally, and we perform about 6,500 operations for trauma. And that's all carried out by 10 orthopaedic trauma surgeons, of whom I am one. We are fortunate in our area because we're the only provider of orthopaedic trauma services in the region. So we see the whole range of injuries, and this is not to say that nobody ever survives our treatment, but more that we have a fairly static population. And so after initial treatment, we do tend to see most of our patients back until they have recovered from their injuries. And that has allowed us over time to develop quite a good understanding of the epidemiology and recovery from injury. And our centre certainly has a particular interest in research, published papers and textbooks. My own practice, I have no legal expertise, but I am a consultant orthopaedic trauma surgeon. I was appointed in 2006. And my own area of practice is in injuries to the musculoskeletal system. So that is maybe slightly different from some of the experts that you've dealt with in the past, where quite a lot of orthopods will tend to confine themselves to a limb or a region of the limb. And certainly some of my colleagues actually prefer the left or right side. In our system, the expertise is in trauma, regardless of which part of the body that refers to. I don't do any cold orthopedic surgery, so I don't do hip or knee replacements. It's all trauma. I've got a couple of cases just to show you the type of practice that I tend to deal with. There is a health warning. There's a couple of slightly gory images. Please do look away or turn your screen off if you don't want to see any blood, and then I'll give you an all clear when that's now completed. So a weekend not very long ago, I was on call and dealt with a French chef who had suffered an unscheduled dismount from a motorcycle at high speed, with injuries to a number of body parts. You can see he had an open fracture of his forearm there, but it had also fractured his pelvis. He had fractured his wrist. You can see all the bones of the wrist are completely separated there. And that took most of the day to piece his various anatomical regions back together again, including a pair of dislocated knees. So one of the pleasures of my job, I guess, is that I get to deal with this wide variety of injury and trauma. One of my least favorite parts is dealing with life-threatening infection. There are some infections that just can't be treated with antibiotics and escape control and progress very rapidly. Necrotizing fasciitis is otherwise known as killer bug, ate my granny, that's popular in the press. And these cases tend to worsen in front of your eyes with a turnover, a doubling time of the bacterial load of about 20 minutes, so frighteningly fast. And these come to us, and again, look away if you don't want to see any gory images, but these require surgical exploration, identification of where the infection has got to by inspecting the deep tissues and continuing to excise more and more tissue until you find it, until finally you're able to excise all of the infected tissue, which then requires prolonged reconstruction, as you can imagine. Not all of my work is quite so gory. This is a straightforward open ankle fracture sustained in a trip and fall in Holyrood Park, just around the corner from the Royal Infirmary. And we also enjoy doing minimal fixation percutaneously. This is the chap 3 months later from that injury, and that's the wound from his open fracture. But these are the wounds from the additional surgery required to fix that fracture. So there's also some delicacy and finesse in what we do. Okay, so the plan is to cover a wide variety of aspects of my practice. These were the points that we agreed on, and I'll try and cover as much of this as we can in the next 20 minutes or so. So starting off with common orthopedic injuries, instructions that I receive cover quite a spectrum of injury, really from no identifiable specific injury to patients suffering high energy trauma, with sort of low and medium energy injuries in between. So something that might exemplify no injury would be repetitive activity, or an occupational element such as occupational lifting, or even the carrying of heavy equipment on a regular basis, resulting in something like back or shoulder pain, and often seemingly affecting public servants. We quite often get instructions to treat low energy injuries in a simple stumble or lift, and that would be something in the line of back pain or a sprained joint, or an exacerbation of a pre-existing back pain or sprained joint. More straightforward injuries are simple trips and falls resulting in ankle or wrist fractures, or some easily identifiable orthopedic injury. And those, from my point of view, are a pleasure to deal with. They're straightforward because there's often objective findings and objective data to back up an opinion, and we'll cover that in a bit more detail later. And then finally, high energy trauma is an area of particular interest, and it's actually medically fairly straightforward. These are really just a combination of fractures, each of which are straightforward to deal with. And from the point of view of the report, the complexity is really in the detail of the interaction of those injuries and injuries to other systems, and the involvement of other specialists, and particularly the requirements for care for that patient going forwards. Helpful instructions. I actually find that instructions are not usually a source of problem for me. Usually instructions are of very high quality. Elements that are important are to know whether this is for the pursuer or the defender, a brief description and a chronology, and a particularly of what's important to the case. And usually an element of explicit instruction is quite helpful. For example, whether it's important that a seatbelt was worn or not, and quite often a direction that something is central to the case. For example, a period of time off work is very helpful in making sure that nothing is missed from the first report that's submitted. More specifically in terms of instructions, I find that the detail comes out in these subsequent stages where there's maybe subsequent correspondence. There are reports from other experts, maybe from the other side. And then sometimes when we move on to joint reports from experts, it's then very helpful to have specific instructions about what's important to the running of the case. Records are a bane of my practice, and I'm sure of yours as well. They're extremely helpful when they're supplied at the same time as the instructions prior to interview and examination. There's clearly quite a range of success in GPs' practices and hospitals, and to how clearly they reproduce records. And I guess we all suffer with illegible, non-sequential, upside-down paperwork, which is unnumbered, which sometimes then makes communication between us difficult. Imaging is very important in my practice. And in Scotland, we're lucky to have a national PACS service, so I can see X-rays taken in the NHS anywhere in the country. But where that's not available, proprietary software like Horos and WeSys is very helpful in order to be able to review those records and images in a timely fashion. I guess the meat of what I was going to talk about today really is the difficulty sometimes in assessing how much in the way of symptoms and restrictions can be attributable to the injury that the client has sustained, and where there's a pre-existing problem, how much a period of exacerbation or acceleration can be attributed. I see quite a spectrum here of how neat and precise I can be. So at one end, there's a femoral fracture, for example, a nice, straightforward, easily identifiable orthopedic injury. Usually there'll be X-rays to show how it was treated, how well it was treated, how well it healed. And there is a substantial body of literature, usually to refer to be able to describe what the expected recovery period would be and the time to return to work and so on. And so I can be fairly precise. At the other end of the spectrum, is the more subjective type of symptom and injury. And these are ones like an exacerbation of back pain where there are very limited objective signs and evidence to pull on. And one is required quite often to make a determination of whether you believe what the client or the pursuer is telling you about their back pain. And that's often clouded by other pre-existing problems of varying medical specificity, like diagnoses of fibromyalgia. And so at one end of the spectrum can be fairly clear. At the other, really one's required to make an assessment of what is really an internal subjective experience on the behalf of the patient, with very little externally to confirm this. So down at that more objective end, I usually include X-rays in my reports, and I think that gives you, as the instructing solicitor or client, a clear explanation. You can make a visual assessment there of what the nature of the injury is and how well it's healed. And that also extends to other body parts, very simple fractures in the hand, and much more serious injuries to the chest, where there are injuries, for example, to lung and great vessels and ribs and so on. But again, it's there in black and white, and is therefore amenable to a fairly clear objective assessment. That also helps in prognosis. Here's an example of a patient with a dislocated and fractured hip, which was well treated but has a poor prognosis. It's gone on to arthritis, and the patient's then had to have a hip replacement. And again, that sequence of events is fairly well understood, and it's possible then to give a fairly clear prognosis as to the likely outcome from that hip replacement. These structural orthopedic injuries are also amenable to examination, so I can demonstrate to you where the patient has objective stiffness and loss of function. And in orthopedics, we're lucky we often have a normal limb to compare the abnormal limb to, and that gives you a very clear indication of the limitation you might expect from the patient, affecting both the upper and lower limbs. And this patient, for example, has developed a frozen shoulder as a result of a shoulder injury, and you can see straight away that her range of movement on the right side is limited. I find these type of images also helpful where there does not seem to be transparency on the part of the client. So this, for example, is a patient who claimed to have sustained a serious injury to her ankle. And it's possible to go back and review x-rays and confirm that there is no significant injury radiographically at the time of injury. And then I find it helpful to get the patient then to indicate where they have their symptoms when I see them. And in this case, she's pointing to a part of the body that is not the same part of the body that she claims was injured. And I think that disparity is also quite helpful in coming to a determination of how likely it is that the patient's symptoms are attributable to the injury. So these clear orthopedic injuries are quite satisfying in terms of being objective. Let's talk on to acceleration and exacerbation, and that will lead us on to some of the less objective situations. In my mind, when I'm asked to comment on the likely period of acceleration or exacerbation, I have something like this graph in mind. If we take the x-axis as being time, and the y-axis there as being the level of mobility that the individual has, maybe as a result of a progressive arthritis or a rheumatological condition. And so over time, these degenerative or inflammatory conditions often deteriorate, and you can mentally imagine, although there's some fluctuation week to week, there will be a gradual deterioration in level of mobility and pain. And then that individual suffers an injury at a certain time point, and then suffers a very significant reduction in mobility because of the injury they suffered. One then expects them to make some sort of recovery, and quite often they reach something of a steady state, which again might fluctuate from week to week, but overall is identifiable as a level. And at some point, the two lines cross, and that difference between the time of injury and the point where those two lines cross is the period of acceleration or exacerbation of their injury. And of course, there's quite a lot of uncertainty involved in this. It's very difficult to pin down because that blue line is simply a projection into the future of what one might expect, and you clearly require a crystal ball in order to be able to identify exactly what that will be. And so there is some degree of subjectivity to these type of assessments. There are certain elements of the assessment that contribute towards being able to come up with a helpful time point for the instructing solicitors or for the court. There's a degree of plausibility of the patient themselves. There's an assessment of the reasonableness of what they are describing in terms of the sequence of events and sequence of symptoms. And quite often going back into the records, it's possible to identify situations where there has been honesty or perhaps lack of honesty or transparency in previous interactions. Mechanism of injury is extremely helpful. Clearly, a high energy motor vehicle collision in which there's been a significant energy transfer is more likely to result in a significant problem in the long term, and I often find engineers' reports quite helpful, and particularly in the converse situation where there appears to have been a very low energy transfer. An engineer's report that describes how low that would be in relation to everyday activities is often very instructive. The presence of a structural injury, either to the individual themselves or perhaps the vehicle in which they were traveling, provides a nice clear indication. And then the examination findings as we've discussed. So to give an example, at one end of the spectrum would be a patient who appears and presents as straightforward, uncomplaining, with no attempt to exaggerate. Their history reveals that they rarely attend their GP, and they have no previous symptoms in the body part concerned. They've had a significant energy transfer with an identifiable injury. They've had some significant post-injury symptoms, but combined with an appropriate examination, and then importantly, a trajectory of recovery as expected. So a patient suffering a physical injury will usually describe a progressive recovery with or without periods of setback. But for example, a patient describing no recovery or worse, a gradual deterioration is usually not describing identifiable structural tissue injury. And so for those sort of patients, a period of acceleration or a period of exacerbation of symptoms is usually a reasonable assessment. At the other end of the spectrum, we see patients who have a history of chronic pain conditions, often involving other parts of the body, or psychiatric or psychological symptoms that might influence their perception of their pain or their perception of their level of function. They may be a regular attender with vague pain symptoms. Most importantly, they may have previous pain at the same site. With regard to the injury, there may be minimal or often no identifiable energy transfer. On assessing the patient, they may well have inappropriate illness behavior, which we'll go on to cover in just a moment in more detail. And I find just popping out of the room or looking through my window and observing patients leaving the premises often quite illuminating as to whether what they've shown you under examination conditions is actually what's happening. Little change in the level of complaint and plausible unexplained symptoms or worsening symptoms all ring alarm bells. But of course, the clincher in this situation is often the provision of a subsequent surveillance imaging, which may show something very different from how they've presented. And in those situations, a far shorter period of acceleration is usually a more reasonable assessment. So let's deal just in the last few minutes with this situation of unexplained pain and restrictions. I always think of this as the dark side of my medical legal practice. Very helpful to me, and I suspect to you, is the work by Gordon Waddell, who is a professor of orthopaedics in Glasgow and is one of the most quoted sources in all of the orthopedic literature since 1965. And he was interested in the difference or the interaction between organic pathology and what he termed the biopsychosocial model of illness, particularly in relation to the back. So the orthopedic expert in some ways has a relatively straightforward task. I can speak to organic pathology, I can speak to expected symptoms and level of function, and I can identify where there is maybe a discrepancy, or maybe where there is no orthopedic explanation for a patient's symptoms, and suggests that there may be an element of inappropriate illness behaviour that may be better commented on by another expert. And Gordon Waddell takes a very interesting long-term view on this, looking back to other phenomena from our past. For example, the phenomenon of the railway injury, which became a medical and medico-legal industry following the introduction of mass transport, and then seemed to disappear from the. We never hear of patients with railway injuries anymore, but I think the same type of patient and the same type of symptoms now present as something very similar. So we perhaps use different words, whereas in relation to railway injuries, people would talk about hysteria, the wandering womb, psychic shock, and neurasthenia. Terms like psychosomatic injuries or psychosomatic symptoms are used since Heinroth coined that term in 1818, and possibly the same collection of symptoms is now recognized more in terms of words like chronic pain and fatigue, fibromyalgia, and functional neurological disorders. There are signs, helpfully, that can be elicited by an orthopaedic surgeon that indicate that the patient's symptoms have a non-organic basis, and we often term these inappropriate illness behaviours. So to run through some of these helpful signs at examination: tenderness, so a patient who identifies light touch as resulting in deep pain is generally implausible. Simulation is helpful. So patients will often identify their limbs being put in a certain position as causing them pain, but the limbs can be placed in the same position under different circumstances. So the classic would be a straight leg raise. If you place a patient flat on the back and lift their legs in the air, they may complain of back pain. But if they're sitting in a chair and you then place the legs in exactly the same position, they produce a different display in terms of affect. And the difference between those two complaints when just indicated that although CRPS often causes a little bit of diagnostic confusion, in fact, it is quite well identified in terms of some objective criteria and can be fairly easily excluded or diagnosed. These other conditions are areas that are overlapping, I think, with orthopedic injury, and are out with my area of expertise, and are often called up, and these other experts in areas of neurology for functional neurological disorders and chronic pain are often helpful as adjuncts to an orthopedic report where there is difficulty in identifying a structural or orthopedic problem. Okay, should we leave that there? So Tim, am I back in the meeting and able to take any questions? Tim, you're currently muted.
I'm on mute. There you go.
Oh, yeah.
Rookie error. Thank you very much, Tim. That was very comprehensive and all-encompassing. Unless there are any questions, I see somebody has asked for the. Somebody has asked for the position that when you were describing the different positions of leg raises, somebody lying on the couch, they can raise their leg, and then somebody sitting up, they couldn't raise their leg. Is that the right way around? I think one of the attendees has missed that description, I think just due to perhaps you're dropping out. And then one other question is, can you recommend the best time to have an orthopedic report? For example, in a standard minor whiplash case, for example, where to get the best available evidence.
Yes,
Would
okay.
a 6-month report be more accurate than to wait for 12 months before having a report? That is a question from
Yes, let's
Christine.
deal with that first. So whiplash is clearly an area of quite a lot of subjectivity, and most patients will recover within 6 months, and the vast majority will recover within a year. If it is purely a whiplash with no identifiable physical cervical spine abnormality, then in my book, after the 1 year point, it's not plausible to point to any nociceptive pain. So that's nociceptive is pain that comes from a physical tissue source. And the condition, in my view, then becomes one of chronic pain, best spoken to by an expert in pain. So I personally would be happy to see patients at 6 months if they are making good progress, and one could reasonably predict that they will either recover or have nuisance level symptoms by the year. And that 6-month point, I think, is probably the most common time to see them. But 1 year from an orthopedic perspective would allow me to tie that one up within my area of expertise. The question of the straight leg raise. So when a patient's lying flat on the examination couch, one part of the examination of back pain is to raise the straight leg up into the air. And it's a part of assessment of radiculopathy. That's a physical injury to a nerve root caused, for example, by a displaced disc. And so it's an important part of a physical examination. Patients with simple mechanical back pain with no nerve impingement will often perceive that movement as being expected to cause pain. And the muscles will go into spasm, and they'll indicate pain in the back or in the buttock. And the reliability of that can be checked by then allowing them to get dressed, placing them in a chair, and then ostensibly examining something else like their feet. And while doing that, the legs can be placed into exactly the same position that they were in when they were lying on their back with the legs in the air. But often a difference in perception on the part of the patient is evident by simply changing the setup. And that indicates a psychological rather than a physical origin to those symptoms.
Well, thank you very much. Thank you, Mr. White, particularly for attending today and giving us your expertise and such an informative talk. There aren't any other questions. I don't have any questions, and I think at the risk of annoying the technological gods, we'll probably call it there, since I can see some more glitching or disruption on the line just now. That's very kind of you to give us your time, and thank you everybody for attending. There'll be another webinar on the 18th of June, and until then, I'm going to call it for this one just now. Thank you very much. Goodbye.
Thanks.
Thank you.
Thank you.